now are on panel 3. This is an ER-positive, HER2-negative metastatic breast cancer case. I'd like to invite our panelists, Dr. Rao, Dr. Badve, and Dr. Mehta, to the table here to join. Welcome. I love in this meeting how the conversations are multidisciplinary and involve endocrinology and integrative medicine and all of the various physician types that we routinely work with to take great care of our patients. So this is wonderful to have you all with us. Now, let's jump right in. This is a 53-year-old postmenopausal woman who's pre-diabetic with obesity, hypertension, and hyperlipidemia. She presents with a T2N1 ER-positive HER2 IHC0 breast cancer 8 years ago and is offered adjuvant chemotherapy. She has a high genomic risk, an oncotype score of 32, and she declined due to concerns over the chemotherapy damaging her good cells. She agrees to post-mastectomy radiation and aromatase inhibitor in the adjuvant setting, for which treatment was given for 2 years and then switched to tamoxifen because of intolerance to AI. We see this quite often. She was able to complete the 5 years of therapy and was offered extended adjuvant endocrine therapy for an additional 5 years, but again declined. Her family history is significant for a cousin who had breast cancer. No other pertinent family history, germline genetic testing was negative. So she has a 3-year disease-free interval from completion of adjuvant endocrine therapy and then presents to her oncologist reporting back pain and a cough. And unfortunately, on imaging, there is evidence of metastatic disease in the bone, and there are widespread lung nodules. A lung nodule is biopsied, and it confirms the diagnosis of metastatic breast cancer, ER-positive, now HER2 1+. Recall, originally the tumor was HER2 0. NGS testing is sent on the tissue up front, and a PIK3CA mutation is identified, no other targetable mutations. And she is started on first-line treatment with letrozole and ribociclib with a response noted on multiple follow-up imaging studies, and she clinically improves. After 19 months, progression of disease is noted in the bone with a few liver lesions that are all less than 2 centimeters. Liver function tests remain normal, and at this point, circulating tumor DNA liquid biopsy is sent and again identifies a PIK3CA mutation and now identifies an ESR1 mutation. She started on elacestrant and has a response for approximately 6 months, at which point then she develops further progression in the liver. Mild elevation in liver functions are noted, but the bilirubin is normal, and she remains with an excellent performance status. At this point, she starts capecitabine, then develops widespread liver progression after 3 months and is given TDXD with a response that is noted on imaging for 11 months and then develops further progression. So I summarized again the case. It's a bit complicated on the bottom. Recall, originally an ER-positive, HER2-negative breast cancer, high oncotype, declined chemo, took adjuvant, this should say actually hormonal therapy, because remember she took a few years of tamoxifen as well. 3 years disease-free interval, presenting with bone and liver mets, known PIK3CA mutation at diagnosis, HER2 low, then goes on to AI, ribo, 19 months response, ESR1 mutation prompts the use of elacestrant, followed by capecitabine, followed by TDXD, and now the question is what to offer for further therapy. So we have a lot of management questions here, and Dr. Rao will take us through the first one, which is, would you have offered first-line inavolisib, fulvestrant, and palbo?
Great. So thank you for this case, which is very typical of what we often see in our clinics. So I just wanted to start with the NCCN guidelines, and this is the most recent version from 2025. I think if you click one more time, yep. So we highlight here that inavolisib with palbo and fulvestrant is listed in the NCCN guidelines for patients who have stage 4 breast cancer that's HR positive, HER2 negative, has a PIK3CA activating mutation. It is a NCCN category of evidence 1, and it's listed as useful in certain circumstances first-line therapy. So here's the study that this is based off of. And we were very excited to see this presented at our San Antonio breast cancer meeting at the end of 2023. So it's called Inavo 120, and it's a phase 3 trial looking at inavolisib or placebo in combination with palbociclib and fulvestrant in patients who have PIK3CA mutated, HR positive, HER2 negative, locally advanced or metastatic breast cancer. And I just want to call out your attention to the criteria. In addition to what I mentioned, these patients who were enrolled on this trial had progression during or within 12 months of adjuvant endocrine therapy completion. So just to pause and go back to our patient for a moment, she had a 3-year disease-free interval, and so she wouldn't have been the exact patient that this trial was meant for, but this is a great trial to keep in mind for those people who progress on their adjuvant AI or within 12 months of completion. Also, these patients were not previously treated for their advanced breast cancer, and they had to meet certain fasting glucose and hemoglobin A1C criteria because we know hyperglycemia is a side effect of our PIK3 inhibitors. So these patients were randomized 1-to-1 to the combination of inavolisib, palbo, and fulvestrant, or placebo, palbo, and fulvestrant, and they were treated until progression of disease or toxicity. And here you can see the baseline characteristics, which were very well balanced between the two groups. And I just wanted to highlight here the endocrine resistance. So about a third of the patients were considered primary endocrine resistant. And in this trial, that was meant that they relapsed while on the first 2 years of adjuvant endocrine therapy. The other 2/3 of patients were secondary endocrine resistance. So these were patients who relapsed while on adjuvant endocrine therapy after at least 2 years, or they relapsed within 12 months of completing their adjuvant endocrine therapy. And here were the results. So we can see that the combination of Inavo with palbo and fulvestrant significantly improved the progression-free survival. The median was 15 months compared to 7.3 months for placebo, palbo, fulvestrant with a hazard ratio of 0.43. And when you look at the different key subgroups, you can see with this forest plot here that all of these patients benefited regardless of their performance status 0 or 1 and their premenopausal status or postmenopausal. In addition, and this is also relevant if we think back to our patients, patients with visceral disease as well as non-visceral seem to benefit, liver metastasis, even multiple sites of organ involvement, as well as primary versus secondary endocrine resistant. Again, all of these patients benefited from the addition of Inavo to the palbo-fulvestrant backbone. What about side effects? When we add a third drug, we always have to be conscious of what we're adding in terms of side effects. You can see that the rates of neutropenia were relatively similar, whether they got inavolisib or not. We know that this is a toxicity from palbociclib that we're all very familiar with managing. What we do see increased in the patients who received inavolisib was stomatitis. There was 50% all grade. There was also hyperglycemia, 58% all grade. Of that, 5.6% of both of these were grades 3 to 4. Diarrhea in about half of the patients, and nausea and rash in about a quarter of the patients. So the summary from this presentation and what led to its FDA approval as well as being in the NCCN guidelines is that this combination with the addition of inavolisib to palbo and fulvestrant demonstrated a statistically significant and clinically meaningful improvement in PFS. Again, the median PFS more than doubled from 7.3 to 15 months. It was too immature to show overall survival, although there did seem to be a trend, and it had a manageable safety profile consistent with what we know about each of these individual drugs. So because of that, we saw the FDA approval for this regimen October 10th of 2024.
So now switching gears, but before we do that, again, I'll just confirm, I think that I know your answer. In this patient case, you would not have offered this
No.
regimen?
I would not have. I think, the key to me was, again, that 3-year disease-free interval between her stopping her 5 years of the adjuvant endocrine therapy and recurring. If she had recurred within a year, if she had developed metastatic disease while she was taking her adjuvant AR tamoxifen, I think in those situations, I would have considered it.
I agree. And now with these data, are you doing NGS testing up front? I know it's best practice to do a biopsy at the time of diagnosis of metastatic disease. We were previously doing that to reconfirm biomarkers, but now with this additional approval, has that changed your practice?
So I do it upfront for both of those reasons, to reconfirm the biomarkers as well as send NGS. Ideally, if we can get tissue, if they have an easily accessible liver, lung metastasis, then we definitely proceed with it. I think the bone-only ones are a little more challenging. But in this case, again, to remind you all, the inavolisib was only for patients who had the PIK3CA mutation, so that is something you want to know. And that's one of those mutations that we believe is one of the truncal mutations of the cancer. So you could have even tested it on the original. There's, I think, a very small percentage that can develop over time, but the majority of PIK3CA mutations originate with the cancer. So, and we see it in about 40% of patients who have breast cancer. So I think in general, now that we have 3 targeted therapies against PIK3CA, it is one of those mutations that's good for us to know, so we can think about what our first line as well as subsequent lines of management would be for any patient.
I agree, and I think the other point that I would highlight with this case is the patient's comorbidities, which are quite reflective of the routine patients we see in clinic. She was pre-diabetic, hypertensive, high cholesterol, that hemoglobin A1C being a little over 6. I think knowing that this may be a class of therapy that she may see in the future may give us some time to optimize glycemic control during first-line therapy so that when she does start the treatment, she may better tolerate it. So I think that's another important consideration and a nice segue into Dr. Mehta's conversations regarding integrative medicine considerations and how to approach patients who are resistant to standard treatments and how integrative therapies may be helpful in improving tolerance. I deliberately inserted that language that we hear not uncommonly when we talk to patients who rightfully have a lot of concerns about the toxicities in the early stage setting. But how would you take us through those conversations?
Thank you, Dr. Mahtani, for your kind invitation to join this wonderful forum. I oftentimes I get a lot of questions about what is integrative medicine and how is it different from alternative medicine. And perhaps some of the saddest days in my career are those days when we had someone come in early with early stage, very treatable breast cancer, and they decided to reject the wonders and amazing technologies of modern medicine and decided to kind of go their own way. And this can be oftentimes because of an inherent mistrust of the medical establishment. I don't think the pandemic did us any favors in that regard. And it can be because of cultural biases that haven't really been appropriately taken into account by us, really. And also a lot of reassurance that when we see anyone in clinic, that they're not going to be dismissed outright if they come to us with questions that are outside the realm of mainstream medicine. So I think that understanding that alternative medicine is using methods of healing in place of modern-day medical technologies, and complementary is really an approach which is used together and in tandem with modern-day technology, mainstream medicine. And that's a really important point to understand. The way I describe how our integrative medicine team works in our practice at Memorial is that if the body's a garden and cancer's an unwelcome weed, it's the job of your surgeon, your oncologist, your radiation oncologist, to address the weed. And it's our job as your integrative medicine team to help you strengthen and nourish the garden. And then how we play a role in the survivorship arena is our goal is to empower our patients with all of the lifestyle and preventive methods that we know of so that they can make the soil of the garden as inhospitable to that weed ever coming back. And so that's how an integrative approach to oncology is really that's what it looks like, boots on the ground in day-to-day clinical practice. And so I think one of the things that we've heard oftentimes is when anyone comes in and says, listen, you know, I'm drinking this tea, or I'm taking this supplement, or I researched this on my own, and you know, I heard that it was good for breast cancer. And what many of us have historically said is, don't do any of that. And actually that is somewhat disempowering. And I think an improved way of really enhancing patient engagement is, well, I'm glad that you have taken it upon yourself to really, you know, use that motivation to get better. And we're going to channel it towards what is in the science. We're going to direct it in a very science-informed and evidence-based way so that you can continue to use those methods that you're already using in a more informed and empowered way. And that's really what the integrative practice is all about. So just in a nutshell, we use physical exercise, we use mind-body medicine techniques, we use nutritional recommendations. We use mind-body medicine interventions very commonly, and we also, you know, we understand that these positive health behaviors are not implemented in a vacuum. They're applied in the context of a home, in the context of a family, in the context of a community. So we say, listen, we have our team, you bring yours. Bring in your family member, bring in your friend with whom you are going to partner in order to apply these positive health behaviors that are gonna help you improve quality of life both during treatment for breast cancer and also when you're living beyond breast cancer. So, you know, very generally speaking, we apply the four most important components of an initial integrative conversation with anyone living beyond breast cancer includes food, mood, move, and snooze. I'm a sleep medicine physician by training. So, you know, oftentimes we have been kind of beaten over the head with diet and exercise recommendations and maybe, you know, there may be even a little bit of fatigue, you know, that we hear you should be eating right, you should be exercising. Well, we start off with a conversation about sleep. And when our patients realize that they can actually achieve better health by getting a good night's rest and by doing less and by letting go, using some of these mind-body medicine techniques that we also apply, that's a really nice initial segue into other conversations about nutrition, physical activity and exercise, as well as mood. And later on, I'll be covering some of the clinical practice guidelines about anxiety and depression, treating anxiety and depression using integrative methods within the setting of breast cancer. So our clinical practice does have nutrition experts. We have mind-body medicine trained psychologists. We have exercise physiologists who aren't personal trainers. They actually have master's level and above training in how to use movement as medicine, particularly as it applies to people who have undergone mastectomy, may have a trace lymphedema. So they're really good in their knowledge base, and our patients have a high degree of comfort working with them and really feel like they facilitate a few sessions that improve their confidence in regaining their exercise routines and really functionality. We have two phenomenal acupuncture practitioners who are also amazing. We use acupuncture in the setting of aromatase inhibitor-associated arthralgias. We use acupuncture for nausea, reduced appetite, sleep concerns. treatment-associated peripheral neuropathy. These are some of the indications that we have wonderful acupuncture practitioners use their healing techniques in order to improve quality of life. We refer out to oncology massage therapists. There are very few massage therapists who are oncology trained out in the community, but we have a good working relationship with the ones who we trust. And that's the other thing, is that, any patient who comes in saying, we have found this alternative medicine practitioner and they're recommending X, Y, and Z. Our integrative medicine clinic is a safe harbor, is a safe space where all of these ideas can be floated, and we can really help them understand whether the things that they are what they're being recommended, whether they are science informed or whether the marketing and salesmanship is leaning out a little beyond the skis of the science, if you will. So really guiding them back to that science-informed and evidence-based methods are really important. Movement as medicine, we use a real baseline of aerobic exercise, 150 minutes of moderate intensity aerobic exercise, or also known as zone 2 cardio. Really great to get the blood flowing and get oxygenated blood to areas of concern. We draw heavily upon the research of Dr. Neil Iyengar and others who really look at body composition. We have a body composition analysis machine in our practice. So I know that in the case, it was noted that that she was obese, but we actually we prefer to see even beyond a BMI. We prefer to see basal metabolic rate. We prefer to see body fat percentage, because body fat, especially when it comes to hormone receptive positive cancers, I'd explain to our patients that body fat is like the reservoir in which a lot of these hormones reside. So when they are decreasing their percent body fat by using some of these exercise guidelines, they're shrinking down the reservoir in which a lot of these estrogens can reside. So when we explain it like that, when we share that it's not just about losing weight, we oftentimes have a cultural, societal preoccupation with losing weight. And perhaps that's not the most appropriate goal. Perhaps a more appropriate goal is reduction of body fat percentage and improvement of muscle tone and bone density, especially while on medications like aromatase inhibitors, so that we can use those evidence-based exercise principles. We get a lot of questions about herbs and vitamins and supplements, and we take a very conservative, less is more approach when it comes to these types of products, particularly in the setting of active treatment. This is a slide that depicts some of the very well-reputed resources that we use. The About Herbs website is a very great resource by Memorial Sloan Kettering, and also, of course, the National Cancer Institute. So these are some of the really nice science-informed resources that we direct our patients to when it comes to herbs and vitamins and supplements. But again, because herbs, anytime we're using plant medicine, these compounds, these plants are very complex in their molecular profiles. So the opportunity for drug-herb interactions is very significant. So it's a very important cautionary note that we provide our patients who are asking about these types of products, and we guide them to products if it is indicated. Vitamin D, for example, supplementation is something that we do very commonly. But if there are certain supplements that it is important for our patient to take, we direct them to those products which are third-party vetted by an independent laboratory for authenticity, purity, and potency. So again, NCC clinical practice guidelines in oncology. I will be discussing some of these in greater detail later on in the afternoon, and I'll turn it over to you, Dr. Mahtani.
That was a great preview of a lot of the discussion that we'll be hearing later this afternoon in Dr. Mehta's dedicated session on integrative medicine. So again, we're back to our case. Now recall the details. I won't go through them again. But now the question of what to do upon progression. This patient had an aromatase inhibitor and ribociclib in the first-line metastatic setting with a response for 19 months. And as you mentioned earlier, Dr. Rao, in terms of mutations that are primary versus acquired, we know the ESR1 mutation is an acquired mutation, and this was a unique situation of having two targets. In this scenario, elacestrant was chosen, and I'll let you take us through some of the data that informs some of the treatment decisions that were made subsequently.
Great. So back to the same slide I showed you about the NCCN guidelines. Here you see FDA-approved agents for patients who have PIK3CA, AKT1, or activating mutations in PTEN. We can use capivasertib along with fulvestrant. And PIK3CA activating mutations, our first targeted agent in this class actually was alpelisib. So both of these with fulvestrant are considered category 1 and preferred second line. You can go to the next slide. So here's just a summary of the data. And this is, again, the first trial that we saw looking at patients who had PIK3CA mutations. SOLAR-1 was a phase 3 trial looking at alpelisib with fulvestrant in this HR-positive, HER2-negative metastatic breast cancer setting. These patients had received prior AI and now had metastatic disease, no previous chemo for advanced disease, no previous fulvestrant, and they could not have had type 1 or uncontrolled type 2 diabetes. So there were 572 patients randomized to either alpelisib with fulvestrant or placebo with fulvestrant. And the primary endpoint here you see on the right, which was PFS in the patient cohort with PIK3CA mutated cancer. And you can see that the median PFS improved from 5.7 to 11 months. So this trial led to the approval of alpelisib and gave us that option to think about for ER-positive patients who had PIK3CA mutations. Few years later, we saw the Capitello 291 study. This was also a phase 3 study, now looking at capivasertib with fulvestrant in AI-resistant, HR-positive, HER2-negative metastatic breast cancer, a similarly designed trial. But the one difference here, and this is probably because of the timing of when this trial was conducted, is that these patients were allowed to have prior CDK4/6 inhibitors. And in fact, the trial required that at least 51% of the study had prior CDK4/6, so it's a little bit more relevant to our population we see today. If we look back at the percentage of patients in SOLAR-1 who had prior CDK4/6, I think it was 5 or 6%. So very, very little, but that's because that was conducted in an era prior to using standard CDK4/6 inhibitors. Here we see the results of adding capivasertib to fulvestrant. The median PFS improved from 3.1 to 7.3 months, and this was observed in all of the key subgroups, including patients who had prior CDK4/6, as well as those who had liver metastasis. If we go back to our NCCN guidelines, we see elacestrant, which is an FDA-approved agent for patients with ESR1 mutations. This is a category 2A, and it's in subsequent lines of therapy. And again, this is what our patient received because she had both an ESR1 and a PIK3CA mutation. Elacestrant was approved based on the EMERALD phase 3 study. So these were patients who had prior endocrine therapy for advanced disease, and one of which had to be given in combination with a CDK4/6 inhibitor. And they were randomized to either elacestrant or investigator's standard of care choice for endocrine therapy, which could be fulvestrant or any one of the AIs. And here you see the primary endpoint of progression-free survival. On the left, all patients, you can see that the progression-free survival was improved. The hazard ratio here is 0.7. And on the right, if we pick out the patients who had ESR1 mutations, you can see that there's even more of a benefit here. If we look at the 6-month PFS for standard of care, 19%, compared to 40.8%, so almost a doubling at that point. Now, if we look at the subgroups on the left, you can see that elacestrant benefited patients who had bone-only metastasis. On the right, you can see that the patients who had liver and or lung metastasis also benefited from elacestrant. These were all patients who had ESR1 mutations. And this case really highlights something that we do see in clinical practice, a patient who has both of these mutations, so an ESR1 as well as a PIK3CA mutated tumor. So the Emerald investigators went back and looked at the patient subgroup of patients who also had PIK3CA mutations. And even in this group, you can see that receiving elacestrant compared to standard of care, these patients did benefit from elacestrant.
So maybe we can pause before we go on to the ADC data and just comment on the choice of elacestrant here. I think this case, it was a little bit easier because she had some comorbidities that made it challenging to consider using capivasertib or certainly alpelisib. But I'll change the case a bit and say she was fit, she wasn't obese, her hemoglobin A1C was 5. She was following with Dr. Mehta and Dr. Iyengar and was completely doing all the right things. In that situation, would you have offered capi or alpelisib and fulvestrant, or would you still have gone with elacestrant?
And it's a great question, and one we face in clinic all the time. I think it's sort of a data-free zone. We really don't know what the right answer is. Personally, I talk to patients about both of the options. We go through the side effects, the monitoring, the potential, and eventually kind of come to a joint decision about what to do.
I agree. I do something very similar. I think from a toxicity profile situation, there's obviously further options to consider when you think of a monotherapy that's well tolerated versus a drug that causes certain other toxicities that we reviewed. But it's an opportunity to individualize treatment. So just to recap the case again, at this point she had gone on to elacestrant, and then I believe she got 3 months of capecitabine and then went on to TDXD as she had HER2 low disease. The original biopsy or the original cancer was IHC 0. This one was IHC 1+, the lung nodule. So maybe you can give us a brief review of the ADCs that we have in this situation.
So I think ADCs has been one of the most exciting areas in the treatment of breast cancer in the last few years. And this slide really nicely summarizes the data we have for ADCs in this ER-positive, HER2-low metastatic breast cancer setting. So we first saw the evidence that trastuzumab deruxtecan was superior to treatment of physician's choice in DESTINY-Breast04. These were patients who were HER2 low. So HER2 low defined as 1+ or 2+, but FISH not amplified. So taking a significant portion of patients that we previously considered HER2 negative and putting them into this new sort of therapeutic subgroup of patients called HER2 low. And here we saw an improvement in the median progression-free survival from 4.2 to 9.6 months, an improvement in median overall survival from 17.6 to 23.9 months. And what always impresses me about the trastuzumab deruxtecan data is the response rates are higher than we see with any other chemotherapies, really. So in DESTINY-Breast04, the patients who received TDXD had an overall response rate of 53% compared to 16% for those who received treatment of physician's choice chemotherapy. DB04, just to remind you all, these patients had 1 line of prior chemotherapy. So DB06 was DESTINY-Breast06 was sort of the next iteration of this trial, looking at trastuzumab deruxtecan again in the HER2 low population. But this trial had 2 additional facets. So one is it included a proportion of patients called HER2 ultra low, and I think Dr. Badve is going to explain to us more what low and ultra low and all of these pathologic situations are now. So I'll defer that to him, but it included patients who were HER2 ultra low, but it also moved TDXD to the first line. So these patients had not received prior chemotherapy. We saw benefits in median progression-free survival. Overall survival has not yet been reported that way, but again, we saw a very high response rate, 56% compared to 32% for standard of choice chemotherapy. TROPiCS-02 is looking at sacituzumab govitecan. So this is an antibody drug conjugate that is to TROP2 antibody. And it was designed similarly compared to treatment of physician's choice. In this HER2 negative ER positive metastatic breast population, we saw an improvement in median progression-free survival, 4 versus 5.5 months. And I don't want you to compare these median PFSs on this slide, even though I've put them next to each other, because these patients on TROPiCS-02 were much more heavily pretreated. I think the point to take away is that it's still superior to standard of care chemotherapy. We also saw an improvement in median overall survival, as well as an improvement in the response rates here. We more recently have seen a fourth ADC enter the space, datopotamab deruxtecan. So this is an anti-TROP2 antibody, but it has a deruxtecan as its chemo payload. And we saw this in the TROPION-Breast01 study, which was a phase 3 trial looking at datopotamab deruxtecan compared to standard chemotherapy. These patients also were previously treated with 1 to 2 lines of chemo, and they were randomized to either Dato-DXd or treatment of physician's choice. And here you can see the median progression-free survival was improved from 4.5 to 6.9 months. And time to subsequent therapy, which is also an important endpoint for patients as well as for physicians, was also improved for patients who received Dato-DXd. So we do still have some unanswered questions. What is the sequencing of ADCs? We really don't have any prospective data telling us that one ADC is effective after another. We do have some retrospective studies that have looked at this, but that's really one of our biggest unanswered questions, because now in this area we have potentially 3 ADCs that can be used. So will one ADC work after another if they have non-resistant payloads? Will it work if they have the same target and different payloads? And those two questions are really getting at the real question is, do patients become resistant to ADCs because they become resistant to the antibody, or they become resistant to the drug? And that's what we don't quite know yet. Is there a preferred initial ADC? Again, we don't have any head-to-head trials in that setting. I think, I would answer that by saying that T-DXd is the only one that has really been used first line after endocrine therapy. And a real unanswered question is, what about optimal combination therapies? So I think there's a lot to look forward to. We really need to identify biomarkers of resistance as well as response, so that we can best pick the right ADC for our patient and their line of therapy.
So with that in mind, I'll just highlight this study that we're leading at Miami Cancer Institute called the CERES trial. This is a phase 2 single-arm study, multi-center. We're doing this in collaboration with UCLA and Emory. This is a relatively small, non-randomized, single-arm phase 2 study looking at patients that are hormone receptor positive, HER2 low, and have received endocrine therapy, considered refractory, and have received a CDK4/6 inhibitor in any line, and most importantly, have been exposed to T-DXd and are either intolerant or progressed on T-DXd, not necessarily as the last prior therapy. And patients are being given SG. So you might think, well, what's exciting about this trial? We already have these drugs available. We're already doing this in clinical practice, and certainly that's true, and we're going to get a lot of real-world evidence in the next couple years about this. I think the real strength of this study is in some of the correlative work that we're planning to do. We're doing biopsies pre-SG and at the time of progression, and also doing circulating tumor biopsies along the way, hopefully to identify blood-based biomarkers as well as tissue-based biomarkers. And then another study that, again, is looking at the sequencing question is the TRADE-DXd study. This is a trial that is looking at Dato-DXd and T-DXd. You see the schema where you start with one or the other, and then at crossover, at progression, crossing over to the other ADC. So important prospective ongoing studies that will hopefully shine some light on this very important question of ADC sequencing. So now let's turn to some of the considerations surrounding pathology, testing, whether we should test on liquid, tissue, both, the timing and concordance. So I'll let you take it away, Dr. Badve.
Sure, thank you very much. So it's always a problem as to decide when to test. And the simple answer is test often, and believe in the results when they are positive. I think that summarizes everything that I'm going to say in the next few minutes. Partly because if you are HER2 positive, for example, you remain HER2 positive throughout the life. Rather, the patient is considered HER2 positive throughout her life. We do not change halfway through the treatment and then start considering it negative if one of the biopsy turns out to be negative. The same happens with HER2 low and all of these things. So let's start with ESR. ESR mutations are extremely uncommon in primary tumors. You get somewhere less than 3% when Suzanne Fuqua's group initially described ESR mutations. Everyone thought, ha, funny, nice to know, but not significant. As we started looking at metastatic cancers, we started noticing that a significant percentage of these patients do have mutations, and they do contribute to therapeutic resistance. So that is what you see in this particular slide, that the mutations in advanced breast cancer jump from 0 in the early stage cancer to 5%, 33%, and even by third line, 40% of cases. So those things are really important. Next. So why are these important? And the reason is fairly simple. Most of these mutations occur in the site where tamoxifen and other fulvestrant and other agents bind to the estrogen receptor. So the ligand binding pocket is really where most of these mutations are. And then what happens is, because of these mutations, the configuration changes, and therefore the drug binding efficacy drops dramatically. And as you can see in the right-hand side of the slide, tamoxifen binding efficacy decreases by 30%, fulvestrant resistant increases by 40%. So these are the kind of situations that happen. So ESR mutation testing, ASCO guidelines basically suggest that you should test for emergence of ESR1 resistance, and then this should be done in a CLIA certified lab. Again, there are multiple additional mutations, many of which we don't know what their functional roles are, but there are some that was indicated in the previous slide that we clearly know that biologically important. ctDNA is a perfect way of testing this because these mutations can be developed either in any one of the metastatic tumors. We have seen data suggesting that metastatic tumors develop these side mutations, not the truncal mutations. We already talked about truncal mutations such as PI3 kinase, which are seen in the primary tumor and seen in most of the metastases, while ESR mutations may not be present uniformly in all the metastases. So therefore, doing blood-based analysis was certainly very helpful. Then we come to the main question of HER2. So we have had a troubled history with HER2. And the simple way of thinking of HER2 is just go back to your garden. In the old days, we were looking for the trees, right? The big, strong trees, the HER2 3+ positivity. And then if we were not sure what's a tree and what's a shrub, we would do a fish and say, okay, I can have a second test to differentiate the trees from the shrubs, and you could use them interchangeably, and any one of them was positive, you called it a tree, and then started treating. Now we are talking about not only the trees, the shrubs, the grass, but we are talking about even the moss that might be there on the ground. And that is your ultra low. Okay, so just think of it as the smallest amount of greenery that you might have on bare soil that might be sufficient to call something positive. Now, why do we get into this situation? The 10% cutoff that ASCO-CIP recommended for calling something even 1+ was based on some archival data where consistency between 2 different assays was used. So some of you might remember, the old data comes from what was called the clinical trials assay, and that was, many of you won't even know that existed. But from that, we had the HERCEP test that came out, and the concordance between the two was greatest at 10%. So that's what the main reason why 10% was chosen. And then we had the intensity and the completeness of positivity that then defined 1+ and 2+ and 3+ categories. So 3+ was strong, complete membrane positivities. 2+ were a little bit weaker, but still had complete membrane positivities. And then 1+ were partial membrane, but still had greater than 10% positivity. There was no real reason for that 10% to be a gold standard, but somehow that persisted. So now we are looking at drugs that are extremely potent and that do not really require that much amount of positivity, partly because drugs like T-DXd bind to the cell membrane, and the toxic payload that is there not only kills the cell, but can also kill adjacent cells. And because of that, very low levels of positivity may be sufficient for the patient to have a response to these agents. And that's the reason we are talking about low and ultra low patients. And in DB06, there was a percentage of patients who had ultra low. Now, this is a study that is cited very often, and it's a complete disaster, okay, for the lack of better words. Why is this a disaster? Because the 18 pathologists were never told that they were trying to differentiate between 0 and 1+ positivity. So they were using the old criteria of 3+ is important, everything else, who cares, patient is not eligible for therapy. 2+, we'll get a fish, okay, so we will regard 2+ with some importance. 0, 1+, no value whatsoever, let's not worry about it. And that's really what led to this extremely poor concordance of 26%. There have been multiple follow-up studies using larger number of pathologists, where the pathologists were told to actually differentiate between 0 and 1, and the concordance there tends to be in the 80% range. So again, not perfect, but still that's work in progress, and we are trying to make sure that we develop techniques and methods for improving concordance. Oh, sorry, yeah. So the main thing to remember about HER2 is HER2 expression is, the 3+ amplification is a completely different category, but lower levels of expression, and we have papers dating back to the late 1990s, where HER2 was recognized as one of the mechanisms of resistance for tamoxifen, right? So upregulation of molecules of HER2 was known as an endocrine resistance pathway. And we are seeing the same thing again and again here, that some of these low levels of expression can be resistance mechanisms to a particular agent. You remove the resistance mechanism, that expression may drop. And so those kind of changes, which are based on protein level, can alter during the course of the disease. And in all of these trials that involved HER2 low, there were primary tumors as well as metastatic tumors that were enrolled, and any one of them being positive was considered enough to be eligible for the trial. So just remember, if you have a primary or a metastatic that is HER2 low, that's sufficient for the patient to be eligible for T-DXd or drugs in a similar manner. So discordance can be seen at various tissue sites, and this is a very nice example of that, where, again, small series, but you can get different levels of protein expression depending on the site of metastasis, and something to remember as you are dealing with this. The problem basically is there are no good ways, apart from tissue analysis, to recognize HER2 low. You cannot use NGS, you cannot use anything else, because this is protein expression at the tumor level. So practical definition of HER2 low, well, it depends on the assay, but it can be up to 81% of patients might be HER2 low. And so we are essentially flipping the equation. In the old days, we were talking about 15 to 20% of patients were HER2 positive. Now we are saying only 15 to 20% of patients might be HER2 negative. Everybody else might be eligible for these new forms of therapy.
Great.
Thank you.
Thank you. So that gives us 10 minutes for questions. Maybe I can get us started while we're waiting in case anybody has questions. I'll ask Dr. Rao, in terms of the DB06 data, now we have the opportunity to utilize TDXD in the first line. How do you see that playing out in your clinic?
It's a great question. I think it's, again, something we have to discuss with our patients. We did see an improvement in median progression-free survival for using TDXD in the first line in DB06, so definitely it has to be a consideration. I think most of us in these ER-positive, HER2-negative metastatic breast cancer patients often go to capecitabine as our first line of post-endocrine therapy. And, a lot of it is because these patients are used to being on something oral, they're used to keeping their hair, all of those things they can continue to do if you put them on capecitabine. So I feel like now it's a real discussion with the patients. Here's our options, here's the data, here's the side effects. I have to say, some of it also depends on, I think, the clinical scenario that the patient is coming with. I've had a patient who was very stable on a CDK4/6 and AI, and all of a sudden, the next scan showed multiple liver mets. That made me a little bit nervous. So that's a patient that I directed more towards TDXD because knowing the increased response rate as well as improvement in progression-free survival, I wanted to use that as my first post-endocrine therapy. But sometimes you have these patients who are progressing in a couple of bones. They're pretty asymptomatic with it. They want to maintain their quality of life. So I think, again, it's involving the patient in the decision-making.
I fully agree. Dr. Bodve, for those of us who are struggling with this HER2 ultra-low designation now in our discussions with our pathologists who seem to be getting a little frustrated with this because obviously we're asking them to use a tool that was not intended to differentiate between these lower levels of HER2 expression until we get updates from ASCO CAP. How are the pathologists how are you reporting this in your clinic or in your practice in terms of percentages or IHC 0 plus, or how are you describing this HER2 ultra low population?
So this has really been a challenge. The ASCO CAP has taken the point of view that their guidelines are what they are, and they are not going to change anything. But if you read the guidelines closely, you will see that in 0 category by IHC, they do define a category where there is a null and IHC 0 with focal staining. So those are the two categories that they are provided. And so we tend to use that second category, IHC 0, focal staining noted. The problem, of course, is, I hope there is no one from Daiichi or AstraZeneca here, but I'm on the global steering committee for the HER2 low, and we have requested access to the slides so as to know and to understand what was the actual definition that was used for ultra low. And in spite of repeated requests by multiple people, we haven't had access to those slides. So we don't know how low is really low. Is 1 in 10 million cells enough? We have no idea. So some of these questions remain unsolved, but right now, even if we see 1 in 10 million, we are going to call it positive because we don't know what the lower limit of low is. So any staining that is there, that is membranous in nature, we are calling it IHC 0 with focal membranous staining. It's an unsatisfactory situation, particularly when you're trying to identify cases for training people. What is 0? What is null? There are some cases that are great, but there are other cases where there may be a little staining artifact, a little bit brown shade somewhere, 1 in a million cells, and then you're basically uncertain as to whether this patient would have qualified or would have responded to drugs such as TDXD. The other complicating factor is right now we are just talking about TDXT, but there are multiple such agents coming down the pike. And whether they would be defining HER2 low in a different manner, we have no idea. So maybe this situation might get extremely complicated. As you saw in San Antonio, the Chinese group has defined a new drug, again, a ADC, SHR, something, I forget the exact name, but that may have a slightly different cutoff. We have no idea as to where these different cutoffs may end up. And so the situation is going to get very complicated very soon because everybody is going to try to develop a drug against HER2 low patients because now it represents 80% of the population. And that's a huge market for any industry. So there will be lots of biosimilars and other agents, bispecific agents that have already been FDA approved. There are other FC-related agents that are approved. So it's a very, very complicated, complex field, and don't know what the future is going to look like.
Thank you.
Sorry, a long-winded answer.
No, but it just illustrates the point that these are complex discussions for sure. So, Dr. Mehta, this question is something that we in our clinical practice hear from patients quite a bit. I've heard it more and more recently. I have many patients asking for ivermectin, either with or in place of traditional therapies. How are you approaching this topic?
You know, I think a little bit of validation goes a long way towards reassurance. And, you know, ivermectin, any of these medications that were initially designed as anti-helminthic agents, so really anti-parasitic, anti-worm type of medications. You know, if you look at the human cell, any human cell, and I'm not an expert here, but if you look at any human cell and you actually look at one of these worm cells, they look kind of similar actually. So you know, the very concept of chemotherapy is to be more toxic to the cancer cells than it is to normal human cells, and the very concept of anti-helminthic or anti-parasitic agents is to kill the worm before it kills the human being. So, I mean, conceptually, like I can understand where, you know, they're coming from, but there really isn't any evidence or any science to support that these medications have any role in oncology. You know, so I think that acknowledging that, you know what, they're doing their own research, they're motivated. I think a key component of an integrative approach to improving quality of life in the context of cancer treatment and survivorship is really to take advantage of this motivation and engage patients in a more constructive way than we have been historically in order to take that motivation into a more science-informed way. I think a little bit of acknowledgement that, you know, I can kind of theoretically see where this story originated and why this has gained so much popularity in the media and gets so much more limelight than things that actually have scientific validity. So I think starting off the conversation like that is important, and then let it evolve. You know, in integrative medicine, we use a lot of motivational interviewing. And so when we provide a recommendation, we listen for resistance talk, or, you know what, I really couldn't do that because, you know, I can't exercise because, you know, I have really bad low back pain as well. So, you know, you roll with the resistance, but then you really engage and draw upon the positive statements that are made by a patient to guide them to what's really in the evidence, in the science.
I love that answer, and I'd also, again, just echo the slide that you showed us with the resources. I think that Memorial Sloan Kettering resource, I've given that to so many patients, and ivermectin is on there along with all of these other supplements, and it goes through where there is evidence, where there is not evidence, and it's been an amazing resource in my practice. I think we have a question here.
Yeah, hi, this is a question for Dr. Rao. So I was just looking at the data that you had on the clinical trials with the new PI3 kinase and AKT inhibitors, and the rates, this is an endocrine question, the rates of hyperglycemia like grade 3 or lower, but they, lower than I should say the alpelisib trials, but they changed the adverse event criteria, right? So they were CTCA5 versus CTCA4, so the 4 used to be based on glucose numbers, whereas 5 is based on starting insulin and hospitalization. So the question, a long introduction to the question, which is basically in clinical practice, do you have a sense that the hyperglycemia is actually less, or is it going to be the same?
I mean, I think that's a great question. I don't know that I can, I think we think it's a little bit less. The criteria for enrollment on the trial were also a little bit broader for capivasertib than they were for alpelisib. So I think there's a lot of factors to think about. I think in clinical practice, we really have to decide how well the patient's diabetes is controlled and how willing they are to work with their endocrinologist and have multiple sugars checked and all of that. So I think it's you bring up some excellent points. Thank you.
So with that, I think we're at the end of this session. I will just say I love the garden analogies. Those were not planned, that they were the same, but I think we have some aspiring botanists here, and thank you for your participation in this panel, wonderful discussions. And with that, I do believe we are now at the 4th panel, the HER2 positive case, and I'll invite Dr. Iyengar back up.
Okay, hopefully you're not tired of me yet. So that was a fantastic discussion, and I am thrilled to announce our next panel, which will be focused on HER2 positive breast cancer. So we'll keep Dr. Badve and Dr. Rao up here, and also would like to invite Dr. Panoff back up to the panel as well. So here we'll have expertise again from pathology, medical oncology, and radiation oncology. And so let's go ahead and jump right into it. So here's our patient case. This is a 56-year-old female with no past medical history, and she's coming in with a new left breast mass. Her mammogram shows a 2.1 centimeter mass in her left breast, as well as 2 abnormally enlarged left axillary lymph nodes. Biopsy confirms an ER/PR positive, HER2 positive by IHC invasive ductal carcinoma. She undergoes a staging workup essentially because she was having some systemic complaints, specifically right upper quadrant pain, and her CT did identify a 1.8 centimeter lesion in segment 8 of her liver that was suspicious for metastatic disease. Fortunately, no biliary ductal dilatation was observed, and her liver enzymes and bilirubin were within normal limits. So she did have a biopsy of that liver lesion, which confirmed invasive carcinoma that was consistent with her breast primary, similarly hormone receptor positive, and HER2 strongly positive by IHC. So she was started on first-line therapy per the standard approach, Cleopatra with taxane, in this case paclitaxel, trastuzumab, and pertuzumab. She received 4 cycles or 12 weeks with Taxol, and her imaging showed a complete response, resolution of the breast primary, resolution of the liver mass, and no evidence of other disease. So the Taxol was held, and she continued on maintenance HP, and because she was hormone receptor positive, letrozole was added to her treatment. After about 16 months on HP and letrozole, her PET-CT shows 2 new liver masses measuring 1.1 centimeters and 1.4 centimeters, so 16 months, pretty good on maintenance therapy, although we always strive for better. Her liver function remained normal, and she continued to be asymptomatic. So the weekly paclitaxel was restarted, and again, after 12 weeks or 4 cycles, she had a partial response this time. One of those liver masses resolved, the other one reduced in size to 0.6 centimeters. The Taxol was held again, and she went back onto her maintenance therapy. This time, after only about 6 months on letrozole and HP, her PET CT showed that liver mass had increased now to 2.2 centimeters, and now she has 2 new bony lesions, one in the sacrum and one in a left rib. She also developed a new headache, and so had MRI of her brain, which showed a 1.2 centimeter mass in the parietal lobe, which was suspicious for metastasis, some mild surrounding edema, but no midline shift. Okay, so now we have progressive disease both systemically and new CNS disease. So she undergoes stereotactic radiation to the parietal lesion, and then her systemic therapy is changed to second-line therapy with trastuzumab deruxtecan. After 4 cycles or 12 weeks of TDXD, she has a complete response and is back to NED. She also has a response in the brain, showing a treated and resolved lesion, and otherwise NED, and she continues on TDXD. So a couple of issues that this case raises here, and we'll start by going over, I'll ask Dr. Badve to go over for us HER2 IHC and ISH in the setting of HER2 amplification and what all of that means. So Dr. Badve.
So thanks again. So as we talked about earlier, we tend to classify IHC protein expression based on the amount of protein and the completeness of membrane. As I said, to call something 1+, 2+, or 3+, we need at least 10% or more of cells to show the expression. If you have an incomplete membrane expression, as you see in the 1+ image, that is sufficient to call it 1+, while for the 2+ and 3+, you need to have complete membrane staining. And the simpler way to recognize 3+ positivity is if at the lowest magnification of the microscope, which is usually 4x or 5x, you can see beautiful membranes, that's your 3+. Anything less than that, and this is like any medical oncologist can do that, you need to see the chain link fence appearance at the lowest magnification that your pathologist might show you. That is 3+. Anything less than that is 2+, and we need to have additional confirmatory assay for it. The other assay for it is the FISH assay, which is fluorescent in situ hybridization, which basically tends to look for DNA level amplification. So we have chromosomal probes that identify the segment of DNA, and then in this particular image, those are seen in the red magenta color, while the same chromosome 17 on which the HER2 gene is located is highlighted by the green color. And typically we tend to use the ratio, and that ratio of the red to green is the the ratio greater than 2 that is used in most assays. You can also do it using chromogenic techniques, and then copy number greater than 6 is what is used, partly because those were the original assays, and original FDA approval was based on copy number greater than 6. So next slide, please. So when you come to the analysis by IHC, it's fairly simple. 3+ needs complete, strong circumferential staining in greater than 10%. As we said, 2+ is complete membrane staining, but less the intensity, so it's not particularly seen at the lowest magnification of 4x. It's seen at 10x or 20x magnification. And then if there's an incomplete membrane staining, you call it 1+, if the frequency is greater than 10%. And then we have IHC 0, which now we classify into separate categories. IHC 0 null, which means nothing is positive at all, and IHC 0 with focal staining when there is some staining. Obviously, 2+ cases, we are not sure, and as I said in the trees versus shrubs analogy, we use the FISH assay as a confirmatory assay to confirm that this case is truly positive. Obviously, all of these assays were developed for the 2+ and 3+ detection. And we always said, don't use alcohol fixative because the protein will be better preserved and you'll get false positivity and all of that. And that's one of the first recommendations of ASCO-CAP, that use formalin rather than alcohol-based fixatives. Again, we have to rethink all of that when you talk about low and ultra-low. So the assay, as Dr. Mahtani mentioned, was not exactly fit for purpose to detect these low levels of expression, but that's what we have. Next.
Great.
So when we come to FISH, remember in the old days, we used to talk about trisomy and monosomy and all of that. So now, instead of using those words, we have divided the FISH results into 5 categories. Your group 1 is your true positive cases, where we have the greater than 4, ratio greater than 2, number of copies greater than 4, and that's your classic positive. Your group 5 is ratio less than 2 and HER2 copies less than 4. And your monosomy, trisomy cases are now where the group 2, 3, and 4 are. Again, the amount of data that we have is very limited. Some people may use alternative probes in these kind of situations to try to better classify them. The amount of data, as I said, is extremely limited, and whether those patients may or may not respond is difficult to say. Dr. Press seems to have evidence that some of these patients do respond, and so he tends to classify these patients better. Group 2, of course, based on single gene assay, would be called positive in the old workup, but the question basically is predominantly about group 3 and group 4. So again, if you have the 1 or 5, you're home and dry, as they say, but anything in between, you need to do additional workup to confirm whether you have a true positive status.
Great, thank you for walking us through that. So this case was also interesting in that it brings up the question with regard to the management of oligometastatic disease. She had originally recurred with a singular hepatic presented with a singular hepatic mass. So I'd like to turn to Dr. Panoff to walk us through data with regard to how we could approach oligometastatic disease.
Thank you. So when we talk about extracranial oligometastatic disease, I think that there's 2 trials in the radiation space that are important. They're both SBRT trials. SBRT stands for stereotactic body radiation, so I'm going to say that acronym a lot. And these 2 trials are the SABRE Comet and then NRG-BR002. So the SABRE Comet trial was a phase 2 trial that, sorry if this is small print. You can see it sort of well there. But so these patients had up to 5 metastatic lesions, and these again were extracranial. And they were randomized at a 1-to-2 ratio of arm 1 was standard of care treatment. So basically that was at dealer's choice medical oncology. And then arm 2 was stereotactic ablative radiation therapy, or SABRE, and the ablation indicates a dose that exceeds a certain biological threshold. And so again, it was a 1-to-2. And so the total number of patients was around 100 patients, and so 33 in the standard of care arm, and then 66 in the SABRE arm. And so what they found in this was that, again, this is a phase 2 trial, but the 5-year overall survival improved for the SABRE arm at 17.7% versus 42.3%. So this is a very strong signal in favor of stereotactic body radiation. And what was interesting also was, there were different primary sites, obviously, and so the breast was decently represented in this cohort. And so this got everyone real excited, and this paper was published, I think, around 2020, 2019, 2020, and it was practice changing, and people started to offer SBRT to patients. And there were some limitations, caveats to this. The primary had to be well controlled. They couldn't have progressive oligomets. So people started to treat with this, okay, because of this data, radiation oncologists. But then the next trial, which was a specific breast trial, BR002, these patients were exclusively metastatic breast cancer patients with 4 less Mets, and they were basically randomized to either, and this was a phase 2-3 trial, and they were randomized 1-to-1 to standard of care systemic therapy, again, MET-onc dealer's choice, or SBRT to all sites of all metastases. Okay, so then this trial found no difference in anything. So progression-free survival was the same, overall survival was the same, and there were plans for a phase 3 trial, and that was aborted because of this. And basically, this was practice changing, and the conclusion was, your guys' therapy is just so good that we're not needed for this type of oligometastatic patient. And there's different types of oligometastatic patients, many types. If you, I don't treat that many. We have like a kind of a team for that, but they have a whole algorithm of different types of oligometastatic patients, including oligoprogressive and oligostable, and et cetera. So this led to now, and this data came out about 2 years ago, I think it was in 2023. Again, people changing their practice, and now most places, especially I think in academics, off trial don't treat this population anymore. And you see that sometimes we'll get sent patients and we'll say to wait, and we'll re-image and watch, and the lesions will respond to the systemic treatment, and then you pat yourself on the back and say, I'm glad I didn't treat that patient. So off trial, we no longer really would treat a patient like this. But there's a lot, but if you go to the next slide, there's many trials that, and this is just a fraction of the ongoing clinical trials specifically for oligometastatic breast cancer, looking at different stereotactic body radiation regimens and treatments. So this could change, and there may be populations where they find there's a benefit of treating. And so none of these trials have actually published results, and when they do, we'll see if there's going to be a change to practice.
Great. Yeah, very interesting.
The other thing I was just going to say, sorry, is that
please.
in the liver situation, that becomes very multidisciplinary because you're going to involve IR, and a lot of times then there's a lot of different treatment options for that. So the liver space gets kind of dicey, I think, and because other people get their hands in it. And so I was going to say about that.
Yeah, no, very helpful, interesting to see how the data has sort of gone back and forth there. And I think, your point about specific populations where we may be seeing differences in the data sets, whether that's by subtype or even treatment or even approach, ablation, and so forth,
Right.
will be really informative. So we'll move now, we'll stick with the radiation theme, but we'll move now to optimal management of brain metastasis, particularly in HER2 positive metastatic breast cancer, and I'll turn it back to Dr. Panoff.
Right. So if you look at these guidelines from ASTRO, ASTRO's American Society of Therapeutic Radiation Oncology, for the non-radiation oncologists here. For breast cancer brain mets, so you can have 1 to 4 unresected, 1 to 2 resected, or then greater than 4 unresected or greater than 2 resected. SRS stands for stereotactic radiosurgery, and that's for the most part gamma knife. Okay, there's other treatment modalities, but that's the best one. It's the most conformal. And so for the guidelines are 1 to 4 unresected SRS alone, 1 to 2 resected SRS alone, so that's post-op. We do post-op gamma knife. And then greater than 4, greater than 2, you kind of have dealer's choice, okay? And if you look at C, it's hard to see, but C is under, all the way on the right, next to the gray box with the parentheses, KPS greater than 70, to the right of that, C says, SRS may be preferred for patients with better prognosis or systemic therapy that is known to be active in the CNS available. And so that's small print, but it should be very large. And in practice, we treat many Mets with gamma knife, and it's really our first choice. We not so infrequently will treat 30 brain mets with gamma knife, and gamma knife all 30 of the brain mets. If people have good PFSs And, for certain histology, again, multidisciplinary, it's going to be talked about, and that's offered because it's obviously labor intensive to do that. So, but the difference in, I'm going to talk about it, neurocognitive sequelae is so profound that if someone has a high KPS and they are, working and high functioning, they want to work, we're going to try to treat them with GK. And so while local therapies such as the gamma knife and whole brain have advanced, there's a risk for serious adverse events, which we're going to talk about. And so also you can have other recurrent sites in addition to the brain mets. So now we're treating a lot of patients with systemic therapy in addition to targeting the brain with radiation. And so the ASCO guidelines have been updated for that. There are these regimens, HER2 climb, and so basically these can be offered. You can hold brain-targeted radiation, or you can give it concurrently with GK, and I'm going to talk about that. But again, this is going to be a multidisciplinary approach where it's determined closely with the medical oncologist what's the best combination or lack of to use. And so what I wanted to show with this is when we talk about these treatments, so we have gamma knife, and then we have whole brain radiation, but there's really an algorithm of this where we first would try for gamma knife because it spares the most brain, and then the next, if a patient is not a gamma knife candidate or SRS candidate, then we would want to treat them not just with regular standard whole brain, but with hippocampal avoiding whole brain, where we can spare the bilateral hippocampi. And if you look at the picture on the left, bottom left, that's illustrating two different patients. The top one is hippocampal avoiding whole brain. The bottom one is just whole brain. And by avoiding these neurological stem cells or progenitor cells, you can really, there's good data, especially with using memantine, that you can preserve neurocognitive function and short-term memory, which is really important. And so this is really like, this is the go-to now for whole brain. So I wanted to show that. And this trial on the right, the data set is from that RTOG, NRG trial that shows that the y-axis is neurocognitive failure and the x is time, and that these patients were randomized to either whole brain and memantine or hippocampal avoiding whole brain and memantine, and you can see the preservation of neurocognition with the hippocampal avoiding radiation. And so we would do that. And it's a more sophisticated technique. You have to use IMRT to treat, which is intensity modulated radiation to spare the hippocampi. And so toxicities associated with treatment, this was a 2017 randomized, phase 3 randomized trial that compared gamma knife or SRS with whole brain radiation. This was not hippocampal avoiding whole brain, but it just illustrates whole brain's much more toxic. And it doesn't even do it justice for that one outcome, cognitive disturbance, because that was significant, 23% versus 16. But when you look at other trials and you look at in practice, the neurocognitive sequelae are very significant at 6 months to a year for people who just have standard whole brain radiation. So we try to really avoid this as much as possible. You can also get leukoencephalopathy, which we see that, and that's deadly. And so you want to avoid whole brain at any cost. And really we would only treat it at this point for patients who have many brain mets when they're involving the hippocampus. So radiation necrosis is a toxicity mostly from SRS. It can be severe, and it's also confusing because it frequently presents as recurrent, and it is very difficult to tease out what it is, and which presents a conundrum because you don't know what to do. And so there's treatment for it, which is Avastin and other corticosteroids, but it can be symptomatic, and people can get hospitalized for it. And so the last item to touch on is the increased use of ADCs with radiation, and this is mostly with SRS. And so this was I think MSK's single institution data that showed increased risk of radiation necrosis when you add ADC. Now, if you tease this out further, so this was TDM1, TDXD, and the sacituzumab, we, Dr. Mahtani actually, in the MCI group, looked at the TDXD data, and we actually found that it was really not, it did not improve necrosis. And for where TDXD is concerned, we actually will treat concurrently with GK because of that data. But the TDM1, there's really a high risk, so that has to be held. And there's many different drugs now where there's a chart where Rupesh Kotecha, who I'm sure you know, he keeps this chart and it has all the different medications, and he has to look at that and coordinate with medical oncology about what they're going to use for SRS. But we have a very aggressive SRS program, as you know. So.
Yeah, great. So on the one hand, nice to see that some of our systemic therapies are having CNS penetration, but on the other hand, it's getting complicated in terms of coordination of the local versus systemic therapies. Great. So thanks for walking us through that. So that sort of segues us into the systemic therapy options. And so here you can see the NCCN guidelines specific to brain metastasis in breast cancer. So let me turn it over to Dr. Rao to walk us through systemic therapy options for brain metastasis. And we can start with our HER2 CLIMB clinical trial.
Great, thank you. So HER2 CLIMB was looking at patients who had metastatic HER2-positive breast cancer with progression after pertuzumab, trastuzumab, and TDM1. And I think the real thing to remember about this trial is that it included patients both with and without brain metastasis. This was one of the only trials at the time that really actively recruited the patients who had brain metastasis, and about half of these patients had brain metastasis. It could be active, stable after treatment, or progressing. So these patients were randomized to either the triplet tucatinib, trastuzumab, capecitabine, or placebo trastuzumab, capecitabine. And here you can see the improvement in median progression-free survival from 4.9 to 7.6 months with the addition of tucatinib. Also on the right, you can see the improvement in overall survival for these patients, 19.2 compared to 24.7 months. And this is looking at, on this slide specifically at all patients. At the bottom, you see the exploratory analysis for patients with and without visceral metastasis. And I won't read through the numbers, but you can see that both groups of patients had an improvement in median overall survival. Well, what about specifically those patients with brain metastasis? And as I mentioned, just a little bit under half of the patients on this trial had brain metastasis. So they were able to do analyses of what was the CNS PFS. So what is the progression in the CNS for those patients with brain metastasis? And on the left of the slide here, you can see that these patients who have brain metastasis have a longer median progression-free survival in the CNS, 4.2 to 9.9 months. And on the right, you can see the patient's overall survival for all patients with brain metastasis, again improved with the addition of tucatinib, 12.5 to 21.6 months. And on the bottom, you see the overall survivals improve for both categories of patients with active brain metastasis as well as those with stable brain metastasis. And another question that came up about tucatinib with this CNS activity is, what about the time to development of new brain metastasis or death? And this analysis on this slide shows that the new brain lesion-free survival was improved for the patients who received tucatinib. So it seems to have activity in patients who have CNS disease, active, stable, as well as some role in preventing the development of new brain metastasis. We know that tucatinib is a TKI, so it has side effects associated with that, the greatest being diarrhea, which was seen in the triplet arm at a total rate of 82%. We know that some of that diarrhea is also from capecitabine, as you see 54% in the placebo arm. And you can see the other toxicities listed here, but I think this just reminds us that we have to be cautious in educating our patients about what to expect when we're putting them on this very active triplet regimen. Here's some guidelines for managing diarrhea for patients who have who go on tucatinib and depending on their grade of diarrhea. And also we can see hepatotoxicity or elevation of the LFTs. And here's some guidelines about holding and then restarting tucatinib in patients who have LFT elevations. This is looking at management of hand-foot syndrome in patients receiving capecitabine. So we know that capecitabine-induced hand-foot syndrome is associated with deteriorated quality of life. And this is really a concern for patients who are on HER2 climb because capecitabine is a critical part of that triplet regimen. So in this trial, 65% of patients receiving the triplet experienced any grade of hand-foot syndrome, 14% experienced grade 3 or higher. And this is showing here that the use of topical diclofenac gel effectively prevented all grades of hand-foot syndrome in patients receiving capecitabine. And this was also associated with a lesser dose reduction of capecitabine. So the trial suggested that topical diclofenac gel could be the new standard of care to prevent capecitabine-associated hand-foot syndrome. And again, just one of those things that we have to think about. Sometimes as oncologists, we're thinking about how to treat the cancer, but we also have to think about how to manage the patient while they're on these treatments. And so I think, this is nice to know that there's something we can do about the hand-foot syndrome other than just reducing the dose.
Thanks for highlighting that data. I actually found this to be so impactful that I'm now offering the diclofenac gel to all of my patients that I prescribe capecitabine to. And being from Memorial, I had to also ask you to talk about the 7-on-7 schedule, which we use exclusively, but was not studied in the HER2 climb regimen. So I was happy to see this data. Could you walk us through this trial?
Sure, and Neil, I'll just say we, at our institution at Rush, we had kind of followed in your footsteps, and we were using the 7-7 regimen for many, many years, so we were also very happy to see this trial come out. So this was looking at a trial of fixed-dose capecitabine. If you remember, the standard dosing of capecitabine is not a fixed dose. It's a 1250 milligrams per meter squared for 14 days, followed by 7 days off. So this trial was looking to see what if we gave capecitabine 1,500 as a fixed dose, twice a day for 7 days on, 7 days off. And you can see the patient characteristics on the right of the slide here, well balanced between the two groups. And what they were able to show here is that the median PFS for the fixed dose and the standard dose did not seem to be significantly different. So I think this just validated for us that the 7-on, 7-off, which we know was more tolerable, is also an acceptable way to give capecitabine. And here you see the reduction in some of the side effects. You can see for fixed dose, the rates of any grade diarrhea was 20% compared to 61% in the standard dose. And when we look at hand-foot syndrome, it was almost cut in half, 27.5 versus 53%. Also, oral mucositis was also significantly reduced.
Great. So yeah, I think between this dosing schema, the diclofenac gel, steroid mouthwash, we can really, manage these adverse effects a lot better than previously. So let's shift gears to TDXD, and if you could walk us through this pooled analysis.
Sure. So just to remind ourselves, the HER2 climb trial was really probably our most exciting thing we had seen in terms of CNS activity for one of our HER2 targeted drugs. Then came along this pooled analysis, which was presented by Sarah Hurvitz at ESMO 2023. And what they did was they looked at the Destiny Breast 01, 02, and 03 trials, looking at TDXD in HER2-positive patients who had metastatic breast cancer and brain metastasis. So you see the trials there on the left, and they ended up with this TDXD pool as well as this comparator brain mets pool. And the characteristics of each patient group are here on the right. And what you can see is that I think this was our first real suggestion that TDXD had some significant activity in the CNS. So on the left, you see the CNS PFS for treated or stable brain metastasis, and there it was a median of 12.3 months versus the comparator arm, 8.7 months. And on the right, we see an even wider separation of the curves for the patients who had untreated and active brain mets. So there, the median CNS PFS was 18.5 months for TDXD and 4 months in the comparator arm. So this gave us a lot of excitement about the fact that TDXD would have some CNS activity as well. And that really brought us to the Destiny Breast 12 trial, which we saw presented at ESMO in 2024. So this was a phase 3b/4 study, and this was specifically now looking in a prospective manner at patients with or without baseline brain mets, but looking at TDXD in this setting. So there were two groups of patients, no baseline brain mets and those with baseline brain mets. You go to the next slide. And here we see the PFS for the patients with baseline brain mets. The 12-month PFS was 61.6%. The median PFS was 17.3 months. So this is really remarkable for this population of patients who had brain metastasis and were treated with TDXD. Here's some of the secondary endpoints. You can see the CNS PFS for the patients with 12 months, 58.9% for the overall population, very similar for patients who had stable versus active. As I mentioned before, I'm always wowed by the response rates that we see with TDXD. So here in these patients with brain metastasis, the confirmed overall response rate was 51%. Very similar again for patients who had stable versus active. And the CNS overall response rate, sorry, that was the overall response rate. On the bottom is the CNS overall response rate, looking at their measurable CNS disease at baseline, and here the CNS ORR is above 70%. So again, just really remarkable data. This slide is just summarizing the overall safety, and I think the main thing to take away from this is that we did not see any new safety signals than we had seen with the previous Destiny trials for TDXD. Specifically, if we look at on the top right, the investigator-reported ILD or pneumonitis, you can see it was 16% in all patients. And I think that's pretty consistent with what we've seen, the 10 to 15% rates reported in previous TDXD trials. So this is now just summarizing our available or emerging systemic treatments with CNS activity in the HER2-positive metastatic setting for patients who have brain mets. As I mentioned, we first saw with HER2 CLIMB that there was a significant improvement in CNS PFS, as well as median progression-free survival and overall survival. Then we had a suggestion of TDXD being active in the brain with the pooled Destiny analysis. Tuxedo was a TDXD single-arm trial, which showed an intracranial response rate of 73%. Camilla was also a single-arm trial. Patients with measurable brain mets had a response rate of 21%, median PFS of 5.5 months. The TBCRC data also looked at looking at a different ADC, TDM1 with neratinib. And here we saw response rates in the high 20s to low 30%. And then NALA is looking at another TKI, neratinib, in combination with capecitabine compared to lapatinib capecitabine, and showing activity in the CNS as well. So I think it's just to summarize this slide to say that we have now multiple systemic treatments that can have CNS activity for these patients with brain mets.
Great. Yeah, that was a lot of data. So, yeah, I think that that is promising, and we're seeing more in the pipeline. But one of the issues, of course, is how do we sequence these therapies, and not just the issue of sequencing ADCs, but we know that unfortunately brain mets can be recurrent, and so how do we sequence some of these TKIs with the ADCs, especially when, as Dr. Rao mentioned, the TKIs that we have available to us are typically partnered both with capecitabine, so raising that kind of re-exposure issue. So I think here what we'll do is we'll segue generally into systemic therapies. We focused on brain metastasis, and now we'll focus more on systemic management. And so for that, I'll turn it back to you, Dr. Rao, to give us this overview.
Great. So this is a slide that really highlights the different types of HER2-targeted therapies we have. We know we started with trastuzumab, which is a monoclonal antibody against HER2. Then we next saw pertuzumab, which binds to a different domain of HER2, again, a monoclonal antibody. Then our first ADC that we saw was TDM1. Then we saw TDXD, and these are both immunoconjugates. TDM1 has emtansine as its payload. TDXD has deruxtecan. They both internalize and dissociate. TDXD has a higher drug-to-antibody ratio, and we also believe it has a bystander effect and a very potent cytotoxic agent. We also know that we have margetuximab, which has similar features to trastuzumab, but is bioengineered to enhance the innate and adaptive immunity, specifically having enhanced affinity for the activating Fc gamma receptors. And then we have the class of drug, the oral TKIs. Tucatinib, I think we talked about a lot in the HER2 CLIMB trial. Neratinib, I mentioned in NALA, and you can see some of the other TKIs listed there on the slide. If we go back to the NCCN guidelines, today, and this may change later this year, but today our first-line treatment is still based on Cleopatra. So looking at pertuzumab, trastuzumab, and a taxane, so docetaxel or paclitaxel. Our second-line treatment, really TDXD is our preferred regimen in the second-line setting. TDM1 is listed as another recommended regimen. Specifically, I think we could consider TDM1 as our second line for patients who we determine are not eligible to receive TDXD for various reasons. And then third line and beyond becomes kind of a grab bag of different options. You can see the HER2 CLIMB regimen, tucatinib, trastuzumab, capecitabine listed at the top there. And I would emphasize that that's, I think, what most of us do use as our third line regimen. They say this may be used as a third or fourth line option and may be preferred in patients with both CNS and systemic progression in the third line or beyond setting. But there's also a caveat in NCCN that it could be given in the second line setting. So if you have a patient that you think is appropriate for that, I think you have something to back that up. Then we have trastuzumab with various chemotherapies. We have trastuzumab with TKI lapatinib. And then we have neratinib with capecitabine or margetuximab with chemotherapy. So let's talk a little bit about the differences between our two ADCs in the HER2 positive setting. On the left, you see TDXD, and on the right, TDM1. TDXD has a topoisomerase 1 inhibitor as its payload, whereas TDM1 has an antimicrotubule emtansine. You can see the drug-to-antibody ratio is higher for TDXD. TDXD has a tumor-selective cleavable linker, as well as evidence of bystander effect. And the trial that compared these two ADCs was DESTINY-Breast03. These were patients who were only treated previously with a trastuzumab and a taxane, and it was a direct head-to-head comparison of TDXD and TDM1. And what we see here is in terms of both progression-free survival and overall survival, there was an advantage to TDXD compared to TDM1. I think if you look specifically at the PFS curves, I'll just point out the hazard ratio of 0.33, which is one of the most remarkable hazard ratios I think we've seen in the breast cancer space. Looking at safety, you can see here the comparisons. Again, I think whenever we think of TDXD, we are all now familiar with some of the toxicities associated with it. Nausea, I think the alopecia is very variable with TDXD, but then again, we have to keep in mind the rates of ILD pneumonitis. And in DESTINY-Breast03, any grade ILD pneumonitis was 15%. So this is a summary of the common adverse events in the key trials looking at TDXD, tucatinib regimen, as well as TDM1. And this is something you could go back to if you're thinking about which regimen and toxicity really is a big player in that. So I've mentioned a couple of times the ILD as a side effect from TDXD. We do have some guidelines that we can use for the management of it. I think one of the most important things if you have a patient with ILD is to differentiate whether they're grade 1 or grade 2. Grade 1 really means that they're asymptomatic. So this is a patient that you just see the findings of ILD on a CT scan. We know that we get CT scans very regularly for these patients for staging. In the Destiny Breast studies, they were done even more frequently to look for ILD, but these patients are asymptomatic. Grade 2 is symptomatic. So these are patients who come in with symptoms, and then they can also have findings on a CT scan. Grade 3 means they have severe symptoms that affect their quality of life, and grade 4 is life-threatening respiratory compromise. And here are the guidelines for management. So if you have a patient with grade 1, you need to hold the TDXD until it's resolved to grade 0, meaning that you don't see any more findings on your imaging. If this resolves in less than or equal to 28 days, you can keep the same dose. If it takes more than 28 days to resolve, you should reduce one dose level, and you can consider steroid treatment. If they're grade 2, I think this is one of the most important points on this slide. You need to permanently discontinue TDXD and promptly initiate corticosteroids. I have found it very helpful to involve a pulmonologist. I've become very good friends with one of our pulmonologists who's an ILD expert at our institution with trying to figure out resolution of these findings as well as management with steroids.
Great. Thank you for walking us through that. So one of the questions, of course, that comes up during first-line therapy, and it was sort of highlighted with this patient, is that maintenance period, right? We know that many of our patients are feeling better once the cytotoxic therapy has stopped, and really efforts to try and prolong that maintenance antibody period where many patients are sort of back to living what they would consider their normal lives has been an area of active research. And recently we've seen some exciting data for opportunities to extend that maintenance setting. And so I'll pass it back to you, Dr. Rao, to walk us through some of the recent data and specifically with a focus on molecular therapy with HER2 blockade.
Great, thanks. This, I think, was one of the most exciting things we had seen at San Antonio this past year. So this slide is just showing you that there is some rationale for blocking both the HER2 and the CDK4/6 pathways. And we saw this in the PATINA trial, which was presented at San Antonio. So these patients were triple positive, or hormone receptor and HER2 positive. They had not had treatment in the advanced setting beyond their induction treatment. So these patients were all treated in a Cleopatra-like regimen with trastuzumab plus minus pertuzumab and a taxane. They received 6 to 8 cycles. And at that point, at the completion of these 6 to 8 cycles of induction chemo and no evidence of disease progression, so they could have had a CR, PR, or stable disease, they were then randomized to either palbociclib with the antibody therapy and endocrine therapy, or just the antibody therapy and endocrine therapy alone, which was our standard of care prior to this. To point out some salient points, 97% of these patients had pertuzumab, 71% trastuzumab, and the overall response rate when they got to the point of randomization was 69%. So remember, patients who had progression of their disease on this induction therapy did not go on the PATINA trial. And here we see the primary endpoint, progression-free survival. For the anti-HER2 and endocrine therapy, the median PFS was 29 months, and it was improved by 15 months to 44.3 months with the addition of palbociclib. This is with a median follow-up of 52.6 months.
44 months PFS. That's
Yeah.
really, really remarkable. I think this was really, really exciting to see that.
Overall survival, I think the biggest thing to say is it's yet immature. I think, with such a long PFS, we're going to have to wait longer to see an impact on overall survival. And here we see the adverse events. I won't go through this line by line, but I just want to summarize for you that there were no new safety signals seen with palbociclib, and the adverse events are pretty much what we would have expected with our familiarity with palbociclib. So now this brings us to, what is our approach for HER2-positive metastatic breast cancer? We generally start out in the first line with our Cleopatra regimen, taxane, trastuzumab, pertuzumab. As I showed you, we can do endocrine with anti-HER2 maintenance. We could, pending approval, I just want to say that the PATINA regimen has not been approved yet by FDA, but we're hoping that that's a regimen that we could think about using, adding palbociclib to that endocrine therapy arm when we are in the maintenance phase. In the second line setting, we're really looking at trastuzumab deruxtecan. If they have active CNS disease, we can still consider trastuzumab deruxtecan, but we could also consider the HER2 Climb regimen. In the third line setting, we have to consider what did they get in the second line setting. So you could either give TDXD or HER2 climb if they haven't had the one before. And this is where TDM1 reappears as a third line drug mostly. And fourth and fifth line and beyond, we have our many options that I showed you on the previous NCCN slide, using other TKIs and margetuximab as well as trastuzumab.
Great. Thank you for highlighting that. So a lot of data coming through, and we're getting to the end of the panel here, so I'll just quickly highlight some of the newer strategies that are coming down the pipeline here. And this is a nice review from Dr. Tarantino and colleagues, which sort of summarizes the various strategic approaches. And I think we are seeing some exciting novel ADCs, in addition to the ones we already have, that are coming down the pipeline. And several of these have different cytotoxic payloads, so it's good to finally have something that has a different MOA, and even different antibody targets, specifically looking at the bispecific antibodies, both the naked antibodies as well as the conjugated antibodies. Several TKIs that Dr. Rao discussed, and then addressing whether or not immunotherapy could be combined with HER2-targeted therapy and improve results there, not only immune modulating ADCs or antibodies like margetuximab, but also considering immune checkpoint blockade as we do in other subtypes. And this is also an area where vaccination or vaccines, cellular therapy, have showed some promise there, and I think we'll continue to see data emerge regarding that approach. But we wanted to highlight some ongoing and completed, soon-to-report trials. Dr. Rao alluded to some of these that I think will might be practice-changing in the near future, and of course we're watching very closely the Destiny Breast 09 trial, for which we expect to see results very soon. And this is looking at first-line Cleopatra regimen versus TDXD, and placebo versus TDXD and pertuzumab. So this will be very interesting to see how we interpret these results, particularly in the setting of something like Cleopatra, which we've had for a very long time, and we have very long follow-up data. So I'm sure we'll have many discussions in terms of how that data set looks and how we might think about our practice. HER2CLIMB-04 is a phase 2 trial that's combining tucatinib with TDXD, and I think this is really interesting. The population will include both patients with and without brain metastasis. So it's a smaller trial, but really getting to that question of, we know that brain metastasis is really problematic for our patients and for their overall outcomes. So perhaps combining two agents with CNS activity may be more impactful, but of course we need to see those data. And then HER2CLIMB-05 is a phase 3 trial combining Herceptin and pertuzumab plus tucatinib or placebo in that maintenance setting. So again, looking at how we can extend that maintenance period. And I think if that trial proves to be positive, then we'll need to start thinking about the various toxicity profiles in terms of how we differentiate what our approach is in the maintenance setting. So a lot of exciting data, and this is just a few of many, a lot of exciting data to come. All right, so we have a little under 10 minutes for questions. I'll open it up to questions at this point. We have a few that are online, and we'll take any in the room. Let me just start while we're getting the microphone. Let me just start with something or a few that have come through online. We did have some unanswered questions from the last panel, but I'll have to focus on the HER2 positive setting here. One of the questions, and actually, Dr. Rao, because you practice similarly as we do, I'll pose this question to you, is not quite applicable to the case here, but a question came in about capecitabine dosing, since we covered the 7-on-7 schedule in the adjuvant setting, and trying to extrapolate that to the CREATE-X approach, which used the labeled dosing of capecitabine. What are you doing in the adjuvant setting with capecitabine?
So in the adjuvant setting, I think earlier we saw the trial data from CREATE-X. We're sticking to the way the trial was done, because I think in the adjuvant setting, you're looking at a curative population. And so without definitive evidence that the 7-7 is not inferior, we're sticking with the 14 on, 7 off.
Yeah, I think that's very fair, and that's essentially, there's a little bit of a mixed opinion at my own institution, but we're largely sticking with the CreateX approach as well. That being said, we do have a fairly low threshold for those patients who are struggling with toxicity to then move to the 7-and-7 regimen. I think particularly given data showing greater dose delivery of capecitabine with the 7-on-7 schedule, as well as the dose density in terms of cancer cell kill with that schedule as well. So theoretically, we should actually, I would expect maybe even greater efficacy, but without data in that setting, clinical data in that setting, I completely agree with your comments.
I have a question. Regarding head-foot syndrome, diclofenac gel, how often did you use, and when do you use it, prophylactically or when the head-foot syndrome starts?
Yeah, do you want to take that?
Go ahead.
Oh, okay. So I have started now. I think there's a lot of variability of practice, but I have started prescribing it, not necessarily prophylactically, but essentially telling patients to keep it on hand, figuratively and literally, but to sort of keep it like we do with loperamide, if you will, and to start using it at the very first signs, even just redness of hand-foot syndrome. I mean, it's tricky, right, because you can't really walk around all day with gel on your hands, but I think especially at night, if you start early, people have really been avoiding the hand-foot syndrome. That being said, there is, issue with your lifestyle and wearing gel on your hands. And so I do find that using the 7-on-7 schedule has also been incredibly helpful.
So you do it for 7 days? And
Yeah,
then
while they're
7 days
on treatment.
Yeah, right. Yeah,
That's right.
But then you don't, right?
Correct.
Okay, thank you. And then only once a day at nighttime? Or?
That's how I start them. I tell folks if you're starting when you have the very initial symptoms,
Sure.
start at night. But the more they can use it, the more effective it'll be.
Okay, great. Thank you.
Mm-hmm.
Have you seen any effectiveness in other drug-induced neuropathies like Velcade or anything like that with the diclofenac gel?
Yeah, it's a really interesting question. So, I mean, I'll take a cop out and say that I only treat breast cancer. But that being said, our integrated medicine group actually is doing and has done trials with other agents as well. And I think it's tricky, even with, let's say, a taxane, for example. I mean, I think it's really tricky because when it comes to neuropathy, the mechanism, of course, is a bit different, and then depends on the particular drug that you're using as well. And so right now, I'm not using it, for example, with other drugs that induce neuropathy, because I haven't really seen convincing clinical data just yet. But I think some of those trials will help to shed some light on that question. I also think that there are some other approaches, pharmacologic approaches that are more mechanism specific to pair with the specific drug that you're using that are being tested right now. So for now, I'm just using it with capecitabine.
I have a question but it's for the last case, but for TDXD. So these responses are obviously incredible. And so for a patient who they're ready, they're at that line where you would consider it, but the HER2 isn't there, the pathologically is not there. Do you consider just biopsying other sites if they have many different sites to get it because of the heterogeneity? Do you do that?
I think the short answer is yes. But before I do that, if I don't have to do a biopsy for any other reason, I'll go back to any of their prior specimens. And even if they were HER2 1+ on their original breast cancer 5 years ago, I'll say they're HER2 low and treat them.
Yeah, and there was some really interesting data, right? Where essentially the more you biopsy, and this was unsurprising, but the more you biopsy, the more likely you are to find HER2 low expression or HER2 even positive expression. And so, yeah, that's also my approach is just keep biopsying. You have another question?
Thanks. Can you walk me through your approach with grade 1 ILD for your TDXT patients? Whether you're able to hold or continue, just for grade 1 asymptomatic patients.
Yeah, Dr. Rao, do you want to re-review?
Sure. So grade 1, again, is when they don't have any symptoms, but you just found it on imaging. So in those cases, we hold it. I think the recommendations for when you do the first scan, I think are, they were on one of the slides. In practice, I usually do the first scan at about 3 to 4 weeks out. In terms of treating with steroids, it says you can consider treating with steroids. That's where I really find the pulmonologist to be helpful because, at the same time, you don't want to just be giving steroids to everybody, especially if they're asymptomatic. But then again, depending on the degree of involvement of the lungs, things like that. I think the other thing to keep in mind is when they get to grade 2, I had a patient earlier this year who had findings on her CT scan. She came in and she had a cough, but she had a bunch of other upper respiratory infections. And she said, oh, my daughter and grandson have been sick with RSV. And sure enough, I did a respiratory panel on her and she tested positive for RSV. So then I was a little bit stuck because are her symptoms from the TDXD ILD? Are her symptoms from a coexisting viral infection? And she just incidentally had TDXD found. So again, with the help of pulmonary and all of that, I decided to call her grade 1 because I really thought her symptoms were from her viral infection. And we saw resolution of her findings and I put her back on it. So I think the other key with the grade 1 is that you can restart it. If the findings on CT don't resolve within 28 days, you're supposed to do a 1-dose reduction. But with grade 2, if they have any symptoms, you have to permanently discontinue.
Great. Okay, so we're at the end of the, okay, I'll take one more question. Yes.
So I know when we decide on the anti-HER2, we look at the echocardiograms. And in this part of Florida, we see a lot of older patients who have some cardiac conditions and a low ejection fraction. What would be the approach if somebody has that and patient is not even a surgical candidate because of that, and the cardiologist is waiting for the cardiac function to improve? So are there any other HER2 agents we can use to sort of treat the disease or at least stabilize it before going for surgery?
And so you're talking specifically in the neoadjuvant setting?
Yes.
Yeah, that is a challenge. I'll punt it to you, Dr. Rao, and then I just had a case like this, so I can happy to weigh in.
I don't think we have any standard, approved other alternative HER2 targeted agents in that setting. I think it's really important to work with your cardiologist or cardio-oncologist. I'd be interested to hear about your case.
Yeah, absolutely. So there are cardio-oncology trials that are going on right now, and in fact, we're in the process. The International Society of Cardio-Oncology is in the process. Actually, I shouldn't say in the process. The paper was just accepted with regard to guidelines for cardiac management, both in the setting of HER2-directed therapy and not. And there are some interesting trials going on with remodeling agents, beta blockers and ACE inhibitors, to approach this. So this is exactly, I agree, this is exactly what I do is I involve a cardio-oncologist. I know they're not readily available everywhere, so that can be a challenge as well. But I do involve a cardio-oncologist because depending on the type of dysfunction that a patient has, whether there's wall motion abnormalities and so forth, and the rest of their kind of functional and comorbid status, I think you can potentially tread carefully in borderline cases, potentially with the use of a remodeling agent, cardiac remodeling agent. Of course, if it's more severe than that, then we start to think about, are there other approaches we can take in terms of maybe not an antibody, although unfortunately in the TKI trials, patients with cardiac dysfunction were also excluded. So it's a little bit unanswered there, although there are retrospective series to suggest that cardiac dysfunction, and we know from the prospective trial, is far less with some of the TKIs, but so too may be efficacy. So I think it's really, the situation you outline is one in which I do try to get the opinion of a cardio-oncologist to really specifically characterize beyond just the LVEF, the nature of the cardiac dysfunction.
One more question for a BRCA mutated patient who also has HER2 positive. Would you use the PARP inhibitor as adjuvant if it's for a local recurrence?
I don't think those patients were on Olympia, so I don't think we really have the data to say. I think, theoretically, knowing how PARPs work and knowing the mutation, the BRCA mutations, I think we'd all feel tempted to. I haven't run across that situation in clinical practice.
Yeah, I haven't either, but
I had one patient who was BRCA positive and was treated up north, and now is here and has an axillary recurrence, multiple nodes positive, which are resected, and she is on adjuvant, anti-HER2. But when so she's triple positive and BRCA positive.
Wow.
So a younger woman who needs more, adjuvant treatment because it's a local relapse only
Right.
with no other metastatic disease. So would you use a CDK4/6 with endocrine therapy? What sort of maintenance HER2 therapy would you use? Because she had residual disease on THP,
yeah.
TCHP actually. So would you use TDM1 and then add a CDK4/6 after with endocrine therapy and a PARP inhibitor later?
Yeah, that's a challenge. So, we've had certainly cases like this, not with the BRCA, but everything else that you've highlighted is interesting. And, I think that here, the conversation that I would have with the patient sort of goes, this is what we have data for, and this is what we don't have data for. And then, in terms of the specifics that you outlined, I think, of course, we do have data for TDM1 in that setting. This is exactly the type of patient that I would also want to put on the adjuvant TDXD trial, and hopefully we'll have data there soon. Given all the remarkable responses we've seen with TDXD, I would hope that we'll have similar outcomes in the adjuvant trial. But in terms of current standard of care, I would prioritize where we do have data. So that for that patient, I would likely do TDM1 plus hormone therapy. And then the question about CDK4/6, I think it's interesting because we have data sets where CDK4/6 inhibition and HER2 therapy was not successful in the adjuvant setting, and then we have data sets now in the metastatic setting where we do see success, and I wonder how much of that is related to the type of induction chemotherapy and so forth. So I think in that scenario, I would finish out the TDM1. And then I would probably have a conversation with the patient saying, we don't have data. And then, of course, whether you can get approval or not for the drug is another question. But I think I would have that discussion with the patient, especially I think you mentioned she's a young, otherwise functional, healthy woman. You're in the curative setting. So I think it's worthwhile to have that conversation. It's burdensome, right? Because you also don't want to make the patient to feel like they have to, make that decision or do everything they possibly can. So I'm typically very clear about, if they're suffering a lot of toxicity as well, then I might shy away from it. CDK4/6 in that setting, especially something like ribociclib, is pretty well tolerated. I would not do that with HER2-directed therapy, given the concerns and lack of data with regard to cardiac safety. But in terms of sequencing, as long as everything's looking okay from a toxicity standpoint, I would raise at least the CDK4/6 inhibitor. As Dr. Rao mentioned, we don't have data for PARP inhibition in the HER2-positive setting or in that specific setting. All right. Thank you, everyone.